Hello, my name is Nicole Asonganyi, and I'm a fourth-year pharmacy student. I wanted to discuss intranasal midazolam in pediatric patients. So just some quick learning objectives to help us focus our thinking. We want to identify indications and mechanism of action of midazolam, then recognize different administration methods of intranasal formulations of midazolam, then evaluate relevant literature that supports its use in pediatric patients, and then lastly just understand some key counseling points for intranasal midazolam. Just as a quick background to illustrate how relevant this is to patients, we do know that seizure clusters are very common in those with refractory epilepsy. In fact, more than 150,000 to 200,000 people in the United States that have uncontrolled epilepsy will also experience seizure clusters. Now, seizure clusters can be referred to as acute repetitive seizures, and this is loosely defined as just an increase in the number of seizures typically seen in patients. These will start and stop but occur in groups one right after another. Benzodiazepines are commonly our first-line agents in acute management of seizure clusters, and these help us prevent physical injury and neurological damage, avoid progression to status epilepticus, and reduce emergency room visits. Quite typically, we will see administration of rectal diazepam, but we do want to focus on midazolam and how we can administer it differently from diazepam. There are several other indications for midazolam in pediatric patients, including sedation, reducing anxiety, and amnesia prior to procedure or anesthesia, and of course sedation and mechanical ventilation. Lastly, we do know that we can use this in status epilepticus. Now, looking to our most recent edition of our intranasal formulations of midazolam, we can use them for acute treatment of seizures in patients who require control of intermittent bouts of increased seizure activity, meaning our seizure clusters or acute repetitive seizures. Now, in looking at the mechanism of action of midazolam, this is considered a benzodiazepine, meaning that it's an allosteric modulator of the GABA-A receptor. GABA is a major inhibitory neurotransmitter in the brain, so by allowing for enhanced affinity of the receptor and for more GABA binding, we are able to decrease excitability of neurons. Additionally, we are increasing the frequency of chloride channel opening and increasing chloride influx, thus inhibiting the nerve signal. Considering the other options that we have for emergent treatment of seizures, what makes inhaled midazolam so different? Some of the benefits of using intranasal midazolam include that there's an ability to administer the drug at home during an episode of seizure clusters. It's also much easier to administer this drug than rectal formulations of benzodiazepines, which we typically see prescribed to patients. This is usually rectal diazepam. There's also no refrigeration or IV line required to administer the drug. Lastly, atomizer devices are used in these intranasal formulations typically to allow for rapid distribution of particles and quick absorption. There are two forms of midazolam that we can use intranasally to give patients for seizure clusters. Firstly, you may notice the brand name Versed can be used intranasally. In patients 1 to 5 months of age, you can utilize 0.2 milligrams per kilogram once with a max dose of 10 milligrams per dose. Then in infants or children 6 months and older, you can use 0.2 milligrams per kilogram, again with a max of 10 milligrams per dose. What's different here is that you may repeat the dose once to a total max of 0.4 milligrams per kilogram. There are starter kits available of this formulation. However, parents or caretakers can be given just the vials of midazolam and then the appropriate needles and syringes to draw up the dose. The syringe and mucosal atomizer device are used together in order to administer the appropriate dose for their child. First, they would connect the needle or adapter to the syringe and then draw up the appropriate dose if it's not a pre-filled syringe for them. Then they would attach the atomizer to the syringe, which you can see in the picture on the right side of the screen, and then aim the atomizer in the correct position in their nose, administer half the dose, and then repeat that in the other nostril. Effects of the dose should be seen in approximately 2 to 3 minutes, and if they're not seen at that time, that's when, in some cases, you could repeat the dose, or you would need to contact 911 or go to the emergency room. Nasolam, or midazolam nasal spray, has been most recently approved for its sole indication in seizure clusters. Dosing for this will be 5 milligrams administered as one spray into one nostril, with a max of 10 milligrams per dose per episode. Knowing that the max is 10 milligrams per dose, we can administer this additional spray into the opposite nostril after 10 minutes only if the patient has not responded to the initial dose. What separates this nasal spray from the midazolam that can be administered with a syringe and the atomizer is that this comes as a single-dose nasal spray unit, and it's only approved for use in patients 12 years and older. In order to administer the drug, parents or caretakers can remove the unit from the packaging, then place the tip of the nozzle into the nostril, and press the plunger firmly to deliver the dose. This is further illustrated in the picture on the right side of the screen, showing you how you would use the dose or administer the dose. One of the most important things to counsel on when giving this drug to patients is to make sure that parents or those who will be administering the intranasal midazolam understand how to identify seizure clusters and when they can use this product appropriately. In addition to this, we want to make sure they understand that they should not be administering the drug by mouth, and it will only be administered intranasally. Then we also want to confirm that they understand if they're using the Nasolam nasal spray, they do not want to test or prime the nasal spray before use. Remember, this comes as a single dose unit, so if they do try and test or prime the nasal spray, they will have wasted the dose. If using more than one dose in these patients, they need to be reminded that they need to switch nostrils with each dose. And additionally, they do not want to administer a second dose if the patient has signs of respiratory depression, like excessive sedation or trouble breathing. Below, you see some common adverse effects to look out for and to notify parents and caregivers of, such as sedation, drowsiness and sleepiness, and nose and throat irritation. Then we have some rare adverse effects to look out for in these patients, which is respiratory depression and hypotension. Next, I want to highlight some of the evidence that we have that allows us to support the use of intranasal midazolam. We do have several studies comparing the efficacy of intranasal midazolam administration to our other option of rectal diazepam in the outpatient setting. Here we focus on intranasal midazolam versus rectal diazepam for the home treatment of acute seizures in pediatric patients with epilepsy. This was an open-label prospective study which had patients randomized in either the intranasal midazolam group or rectal diazepam. This included 358 pediatric patients who were less than 18 years, and they received either 0.2 milligrams per kilogram of intranasal midazolam with a max of 10 milligrams, or rectal diazepam at 0.3 to 0.5 milligrams per kilogram with a max of 20 milligrams. And this was administered for seizures that occurred at home only if they lasted more than 5 minutes. The primary outcome of this trial was the total seizure time after the medication was administered. In the intranasal midazolam group, the median time to cessation of a seizure was 3 minutes. In the rectal diazepam group, the median time was 4.3 minutes. Here you can see that there's a difference of 1.3 minutes in the cessation of seizure compared to these two drugs, meaning that there was no statistically significant difference between intranasal midazolam or diazepam based on our p-value of 0.09. Next, the clinical trial that allowed for approval of Nasolam, or the midazolam nasal spray, was referred to as Artemis 1. This was acute rescue therapy in epilepsy with midazolam intranasal spray. This was a randomized double-blind placebo-controlled trial that included 201 pediatric patients. Patients were randomized to either receive Nasolam 5 milligrams or placebo. Patients did have the option to receive an open-label 5 milligram dose of Nasolam to be administered between 10 minutes to 6 hours after the first dose, if the patient had persistent or recurrent seizure activity. The primary outcome here was determined as successful treatment, meaning that there was termination of seizures within 10 minutes after the initial blinded dose and the absence of a recurrent seizure within 6 hours. To the right of the screen, you can see the results of this study, with 53.7% of patients in the Nasolam group having successful treatment, and then 34.3% of patients in the placebo group having successful treatment. Here the p-value is 0.011, which is less than 0.05, meaning that this was statistically significant in proving that Nasolam was efficacious in reducing seizures within 10 minutes and also having an absence of recurrent seizures within 6 hours. To conclude, based on what we know, intranasal midazolam is a great option for our epileptic patients and is appropriate for outpatient use. While administration is designed to be much simpler than our other options such as rectal diazepam, counseling will be an essential component to this in order to prevent error, especially when using intranasal Versed, which requires the mucosal atomization device. Teaching parents or caretakers how to appropriately use syringes or how to appropriately administer the nasal spray is necessary in order to make sure they understand when to use midazolam as well as how to recognize signs of error or signs of adverse reaction. Lastly, the nasal spray formulation of midazolam may be an even more simplified option for patients. However, we do still need to consider that this is only FDA approved for patients who are 12 years and older, and we must consider that this formulation is not yet available at all pharmacies in the United States. It is expected to be made available later this year. Thank you to those of you who are watching this presentation, and I hope this provided some interesting and helpful information on intranasal midazolam in pediatric patients.